The NCD Alliance's mission is to try and unite and the voice of civil society for action on NCDs in terms of prevention and care.
You don't realise I had lots of periods and periods of depression throughout my life, and it took until 2021 for me to really understand that I'd never had depression without a flare or limited mobility or when I was in chronic pain, and for me that's just not talked about enough. You will see your medical professional or whatever, and nobody asks me how I'm feeling or how I slept or how are my relationships and these sort of things.
This again is the key for choosing the treatment. The treatment is not just the prescription, but to talk about the triggers, to talk about the priority of burden, which sometimes is not just to get rid of the skin lesions, but there may be more urgent problems. And so this all needs to be included. And luckily, there are ways to standardize this, to make use of questionnaires like the WHO. We use the WHO-5 to understand the well-being of the patients, of course, DLQI, many more. But these are just aids.
With good advocacy, the key is to understand the mechanism of decision-making. It's all very well to have the evidence and the arguments and speak from the heart, but you have to know how the mechanisms work. What we've had to do is show how our issues are relevant to other existing global health priorities like AIDS and HIV, like maternal and child health.
For the psoriatic people, we can enter through the window in all these program and not from the door.
I like your metaphor of through the door or through the window, but I think maybe it's not so much through the window, it's just coming in at the same time as somebody else. That's what we need to do. We have to show that we are invited in with them. We have a relationship to these issues which are put on these things. Policymakers love everything to be simple and in grids and lines, and unfortunately it's the advocate's job to show why we're relevant.
I see my dermatologist more often than my GP. You might fall into a rotation. You don't see the same GP every time you visit. So you kind of have to have in your backpack that story, what have you tried, what are my prescriptions, even though they're in a central database. I tend to be that bridge, that gap between my dermatologist and my GP.
Biopsychosocial concept comes from family health, and it means look on the patients on the whole, on his psychological aspects, social aspects, and medical aspects. And for that, what happens with the family physician, the first time they sit with the patient, the first time they meet with the patient, they would meet for 1 hour, okay? 1 hour. And they would discuss with this new patient, not about his disease, but about his family and social issues. Is he working? Is he married? And so on. So I think this should be brought into dermatology. And I think in every country in the world, healthcare managers, officers, we can allocate this special appointment.
I think for me, the main gap to add on what Arnon said, talking about position papers and information, is again that information that is sort of based and guided towards the bottom tier of treatment.